Hello everyone. So this week's unit is going to be on ergonomics and posture. So we'll dive right into that today. I'll have a short little lecture here for you, and then I have 3 articles that I'm going to post, and then we'll have time on Tuesday to talk about questions from the lecture, and then we'll get into lab after that. We might have a few guest lectures on this. That's Darcy and Thor, my 2 dogs. They're a little restless with me at home right now and ready to go to the dog park, so you might hear them chime in a few times throughout, and I apologize ahead of time for that. Okay, so just general objectives are listed here. We want to talk about just the national burden of work-related musculoskeletal injury, define just some basic principles of ergonomics, and understand certain variables that can place workers at risk for musculoskeletal injury. We want to talk about just how we fit into all of this as PTs, and then just apply a little bit of current evidence to practice and to help guide your practice in the future. So the goal of ergonomics is to reduce stress and eliminate injuries and disorders associated with the overuse of muscles, bad posture, and repeated tasks. How do we accomplish this? By designing tasks, workspaces, controls, displays, tools, lighting, and equipment to fit employees' physical capabilities and limitations. So according to the Bureau of Labor Statistics, it's estimated that work-related MSK injuries cost somewhere from $45 to $54 billion annually, which is a lot of money imposed on the healthcare system, and this is just in regards to workers' comp claims alone. I have a high volume of patients that come in with musculoskeletal injuries that they attribute to some aggravating factors at work, but they're not filed as a workers' comp claim. So I actually think that this figure is probably much higher. It accounts for 30% more lost days of work compared to just any other type of an injury or illness. So just musculoskeletal injury alone, 30% more lost days of work. And in general, we're looking at about 400,000 injuries each year. So that makes up a big patient population in the health profession in general, leading cause of pain and disability in the workplace as well. So let's just talk about injury a little bit more. This will probably be a review for you. So an musculoskeletal injury occurs when the mechanical overload is greater than the load-bearing capacity of the musculoskeletal system. So we've got, our acute injuries and our chronic injuries. And an acute injury is typically painful, and it's often immediately limit function. So typically there's a clear mechanism of injury, short-term heavy load imposed on the system, sudden failure of the system. Chronic injury is more progressive. You see progressive pain and dysfunction over time, and at work it may initially be ignored because there may not be a significant functional impairment initially. This is more a result from a longer-term overload to the system without adequate recovery in between. So our goal, or the goal of ergonomics in general, is to balance the requirements of the work with the capacity of the worker. So when we think about worker capacity, what that just means is the worker's current level of ability to perform the physical demands of a specific job. There's different types of external controls that we can apply to try to modify the work requirements. So you have administrative controls, which are changes in the way that the work for a job is performed or scheduled or assigned in order to reduce the magnitude, frequency, or duration of exposure to a potential risk factor for injury. Engineering controls are actual modifications to a workstation or tools to reduce the exposure to specific risk factors for injury, whether that's awkward posture, repeated motion, excessive exertion. So when we think about where we fit into this as physical therapists, I think we fit into either side of the scale. I think on one side of the scale we can help with education and recommendations on equipment and activity modification to help balance the requirements of the actual job or work itself. But I think we also have the ability to improve the capacity of the worker through our training and our interventions. So this is just a little picture that kind of shows you the distribution of musculoskeletal injury by body region. So I think it's pretty obvious just looking at this picture that the top two common work-related complaints are going to be back pain and upper quarter pain. So when I say upper quarter pain, I mean neck, shoulder, elbow, wrist, hand. So are there any injuries that you've learned about so far in your upper extremity unit in MSK that you could tie to maybe a potential work-related injury? You think about that a little bit, maybe jot a couple ideas down for class. So when our patient comes in, whether there's a workers' comp patient or just a patient who maybe sustained a chronic overuse injury at work, and we're learning a little more from them about their requirements to perform their job successfully, about their mechanism of injury, there's three variables that we want to keep in mind. We want to keep in mind the mechanical overload, the duration of exposure, and posture. So these three variables contribute to the total mechanical loading of the MSK system. What mechanical overload is exactly how it sounds. It depends primarily on the magnitude of the force applied to the body. We need to consider the level and action of forces that are applied to the system during whatever work-related task or tasks it is that your patient is required to perform. Duration of exposure is another big one, and there's two parts to this. So there's your repetition frequency and your exposure time. So your repetition frequency is the number of reps, so the number of times they have to do this. Do they have to repeatedly manipulate an object, like turning a screwdriver several times within an hour, or do they just have to lift 2 boxes that are 40 pounds every hour? It's important to figure that part out when you're getting your subjective information from your patient. Additionally, you have your exposure time, which is hours per shift, hours per day, per week, per month. So think about, let's go back to the acute versus the chronic injury when we're talking duration of exposure. An acute injury is going to have a short duration of exposure. It's 1 or 2 reps, very short amount of time, resulting in injury. Versus a more chronic type injury is going to have a longer duration of exposure. So this is repeated microtrauma over time. And then that last variable is posture, and we'll talk about posture a good amount throughout. But basically, you want to ask your patient, how are you performing your task? Are they sitting at a desk for a long period of time, or do they have to bend, lift, twist a lot? Overall, you want to know what are the postural demands of the job that are placed on their musculoskeletal system. Okay, so now we're just going to go over some very general risk factors for musculoskeletal injury in the workplace. We've kind of touched on a couple of these already, but just for review. So the first factor is exerting high-intensity forces. So this is like this is an acute injury. So lifting a heavy load, maybe once, maybe twice, that immediately overloads the system and leads to tissue failure. It could be lifting a heavy load, carrying a heavy load, pulling, pushing heavy objects, but it's a low duration of exposure that results in mechanical overload. Then we have handling heavy objects over a prolonged period. So the duration of exposure is longer and can lead to repeated overload of the system or microtrauma, degenerative changes over time. Examples are just repeated lifting or carrying, pushing, pulling heavier loads. Another risk factor is repeated manipulation of objects. And for this, it doesn't even have to be a heavy object. I think I mentioned earlier, like repeated use of a screwdriver or even like a hammer. What happens is It fatigues and stresses the involved structures, leads to repetitive strain injury or micro-trauma or overuse without adequate recovery of those structures in between. And examples of workers that are at risk for this type of injury include, assembly work or cashier work or even typing. Let's see. Then we have working in unfavorable postures, and what we mean by this is working in like a crouched or hunched forward position over a workstation, or working in a confined space, for example, like a mechanic who has to slide underneath the vehicle and then put his arms overhead to work on the vehicle for prolonged periods of time. So what happens is your stability components and even some of your prime movers just get overloaded from having to maintain that posture for longer than their capacity. And that can lead, again, to, degenerative changes, micro-trauma, repetitive overuse, spasm, fatigue. And then lastly, we have the muscular inactivity. So what we mean by this is sitting for long periods of time or engaging in work tasks that require low muscular demand. So now the musculoskeletal system isn't being adequately loaded to just function at its baseline optimal level. You get a level of deconditioning with this as well. Think about your upper crust syndrome or presentation with this. That would be directly applicable to that as well. Basically, you're just losing the functional capacity. Okay, so what we're going to do now is just kind of get into a little bit more detail and talk about some different educational topics or controls, like ergonomic interventions that we can provide to help our patients. So when we think about lifting or manipulating heavy loads, we want to consider our main variables again. So how heavy is this object? What's the distance of the object from the body? And then how long and how many reps. So what happens if the distance of the load increases from the body? We don't want a long lever arm, correct? Let's think about it. Like, our musculoskeletal system requires a lot of force to move heavy loads in general. And the greatest stress biomechanically is going to be about at L5, S1. That's where the largest moments act here. So the goal with keeping the load close to the body is to decrease that lever arm and decrease the moment of compressive and shear forces on the spine as much as we can. So patient education, we want to lift loads close to the body with both hands, keeping it in the mid-sagittal plane. So we want to avoid bending and rotation of the trunk so that we can decrease the compressive and shear forces as much as possible on the spine. We want to use our hips and our knees more because we have greater muscular power and force generators at those structures. If assistive equipment is present, we always want to use that first so that we're not placing undue stress onto the musculoskeletal system. Lift with a partner rather than individually, and avoid moving loads over obstacles, uneven, slippery routes, steps, or stairs. So here's some pictures of some engineering controls. As you're getting out into your clinical rotations, especially into the hospital and inpatient settings, I really hope that you get to see the mechanical lifts being used for some of the heavier patients. Here's a picture of a lift for heavy boxes in just a manufacturing setting. And then here is a picture of a lift device as well, a forklift, just to assist. So when we have patients that work in manufacturing or factory type settings, it's always important to ask if the assistive devices are present and if they have access to them so that we can get a better idea of the different demands that are placed on the worker when they go back to work. So high force exertion here, we're talking about pushing or pulling heavy objects. So again, we want to consider the direction of the force. Is it a push or a pull? How far is the load from our body? How far of a distance needs to be covered? And what's the posture of the patient or the worker while they're performing this activity? So some educational tips here. We always want to use both hands to help equally distribute the load the best we can. We want to avoid that trunk rotation, lateral flexion, anything that we can do to minimize the compressive and shear forces on our spine. We want to keep the force close to our body to decrease that lever arm. Always use assistive equipment if possible and avoid uneven surfaces or obstacles. So some examples of assistive equipment, lifts, trolleys, dollies. Again, you want to talk to your patients and see if this equipment, number one, is available, and two, if they are able to access it at work. The example on the left, I really like the before-after picture. So if you look at this worker having to move this drum, he's got to pull and rotate and twist and kind of drag it across the floor. And then look how big of a difference just adding that lift makes. You know, it gives them more freedom to just kind of direct without actually applying a significant force to move the object. And then here's just a picture of a dolly on the right. Okay, so then let's talk about posture a little more, and I just gave you a reminder on this side of upper cross syndrome, and that's taken from your article, which is on Canvas. We discussed a bit of some examples of unfavorable working postures already, so whether it's with the arms overhead for long periods of time, then constrained or confined position, prolonged trunk flexion or rotation over a workstation, or prolonged incline seated or crouched positions. Those are all not ideal postures to spend a lot of time in. So as far as that's concerned, when you have to maintain a specific posture in general, it does require force from the musculoskeletal system, from your stabilizers especially, and typically it's going to result in overload of the stabilizers. So in general, with long-term activation too of certain muscle groups, what happens? Think about upper cross, for example, when you have overactive upper traps, for example. They tighten up, they're working way too hard. We get a reduction in circulation to that area, right? So what's one educational pearl that we can use to improve that? Usually we recommend changing positions frequently because that helps to bring the individual out of that specific posture, and it helps to improve circulation as well. Other patient educational tips include bringing the workstation close to the body or the body close to the workstation to enable completion of all tasks within reach. That helps to bring the worker out of that unfavorable posture and into a more mechanically advantageous posture. It prevents them from twisting or reaching outside of their base of support several times to accomplish their task as well. As always, we want to minimize the compressive and shear forces on the spine by avoiding significant flexion, rotation, and lateral flexion. And here are some examples of engineering controls in the workplace that can help to modify unfavorable postures. So if we look at the top pictures, on the left is a picture of a gentleman who is flexed over his workstation, which is this crate, and he's manipulating objects inside of the crate, which just creates a lot of compression and shearing on the spine itself, as well as several other structures. And then if we look on the right, we see that they've added a lift beneath the crate, and what that does is that's raised it off from the level to more of, I guess you could call it a mid-sagittal plane position, but it's also tilted it forward, so now that gentleman doesn't have to lean forward over the edge nearly as much to handle the objects inside. And then the bottom 3 images are just all examples of modifications to take workers out of repeated stooped or crouched down postures to allow for easier just transferring and handling of the materials that they need to complete their job tasks. Okay, so then let's just talk about workstation setup a little bit more. And so remember all of your primary impairments for upper crossed posture from our unit there, and you can also refer to the picture a few slides back as well for a refresher. But let's just think about it for a second. I mean, a lot of Americans spend a lot of time sitting in front of a screen, especially now with all of the technological advances that have been made. We've become very reliant on computers in so many different realms. But I mean, think of your life as a student too right now. Like, how much time do you spend sitting, whether it's in class or studying, or even just watching TV or watching a show on your computer? And at the end of the day, when you've been doing a lot of that, how do you feel? Do you have, back pain or neck pain, headaches, numbness, tingling in your wrists? Like, how do you feel after you've spent that much time? And then let's take it one step further. How are you sitting? What's your posture when you're doing these tasks? Because these are all very, very relevant factors. I mean, we're thinking long duration of exposure. Our musculoskeletal system is being overloaded, especially our stabilizing structures, just from maintaining that less than ideal forward head, rounded shoulders posture. So all of those variables that we discussed in the lecture are very much at play here. So how can we modify this to make people feel better in general? So I've got pictures on the slide of both a standing and a seated workstation. I think the standing workstation is awesome. Standing itself just decreases the compressive forces along the spine by about 35% or so. It improves circulation, and it just does so many great things for the body. But standing workstations, while they're becoming more popular in the workplace, are not always easily accessible. So if it's not accessible, it's good to be able to make some recommendations as far as seated workstations concerned too. So when we're thinking about workstation setup, we want to keep in mind points of contact. So the 4 main points of contact are going to be the ischial tuberosities through the seat pan, which is just the base of the seat, the backrest through the lumbar spine and the soft tissues, the arms and on the armrests, and then the feet and the floor. So your knee and your hip angles are going to control your spinal posture and the posture or position of your pelvis when you're sitting. So like I mentioned earlier, we know that compressive forces are decreased by about 35% through the spine when we're standing, compared to sitting without support, especially through the lumbar spine. We know that there are different ways that we can modify the seat position to decrease compression through the lumbar spine. One example is adding a lumbar support, which if you look, this chair in the picture on the left does have a little bit of a lumbar support there. Another option too is to tilt the chair back. So rather than sitting at a 90-degree angle, tilting it back to about somewhere between 90 and 110 degrees, depending on the individual's comfort, can all help to decrease compression through the lumbar spine. We know that cervical disc pressures increase, especially in that forward head, rounded shoulders posture, and especially through the lower cervical spine. And this correlates pretty consistently to the findings in the literature. Cervical radiculopathy and space-occupying lesions tend to be more prevalent in the lower cervical levels. So, kind of through the kinetic chain, we'll talk about how to modify the rest of the workstation to kind of bring somebody out of that forward head, rounded shoulders posture while they're performing their job tasks. So like I mentioned, we kind of covered lumbar, spine, and pelvis positioning. So let's finish up the lower quarter before we move up to the upper quarter. So we want the knees to rest in a comfortably flexed position, roughly about 90 degrees, at the knees. We want about 2 to 3 centimeter distance between the edge of the chair and the popliteal fold of the knee. If we have too much knee flexion, then we're just going to end up in a posterior pelvic tilt, which can be uncomfortable. But at the same time, we want to make sure that knees are flexed enough so that the feet are in contact with the floor as well. So that brings us to chair height overall. If a patient has access to an adjustable chair, then we want their feet to be comfortably resting on the floor, or if not, resting on some sort of a foot support as well. So let's work our way towards the upper quarter next, and bringing somebody out of that forward head, rounded shoulders posture. So next point of contact would be the elbows on the armrests. We want the armrests to be at a height that the elbows can rest comfortably on there, with the shoulders in a neutral position. If it's too high, we're going to end up with increased shoulder elevation. And we want the elbows to rest comfortably, roughly about 90 degrees. We want the chair to be close enough to the workstation that the forearms and wrists can rest comfortably on the desk to access the keyboard and the mouse without excessive reaching laterally or having to reach forward. Additionally, we want the screen to be roughly about an arm's length away from the individual, and we want the screen to be at eye length so that the worker doesn't have to lean forward or hunch forward to read the screen or to access any of the materials on their desk. With the standing workstation, those upper quarter guidelines are fairly consistent as well. We just need to modify the height of the desk to allow for the elbows to rest comfortably in about 90 degrees flexion, with the forearms and wrists comfortably resting on the surface of the desk as well. Okay, so that brings us back to our risk factor table. So we've kind of gone through and discussed a lot in detail different ways that we can modify either the occupational variables or add in external tools to assist with decreasing the risk of injury. What I want you to do prior to class on Tuesday is to just think of 1 or 2 examples for each risk factor on ways that you could help make recommendations to reduce the risk of injury. So, for example, exerting high-intensity forces. What's an example of an engineering tool that could be implemented into a workplace to help reduce the risk of injury? Or if you're thinking about the 3 variables, mechanical overload, duration of exposure, and posture, what's something you can modify in there to decrease the risk of injury? If you have any questions on that, just free to email me as well. And then we're just going to end with a brief literature review. These are concerning the 3 articles that I posted on Canvas as well. The first is a randomized control trial, the second is a review paper, and the third is a Cochrane review. Just to give us an idea of where all of this stands in the literature, to give you some guidance in how to incorporate this into your practice one day. So the first article was a randomized controls trial that focused just on ergonomic workstation setup. So there you had your intervention group and your control group. The intervention group received an ergonomic training session, a brochure, and then they had their workstation setup modified based on that. And then they took all of their self-report measures at the beginning of the trial, and then they did it 6 months later at the end. What the investigators determined was that there's a significant decrease in intensity, duration, and frequency of the upper quarter complaints in the intervention group, as well as improved self-report measures of function. So what this kind of tells us that at least in that 6-month window, changes to workstation setup can lead to improvements in symptoms and function for desk workers with upper extremity or upper quarter complaints. The second review paper came out in 2013. They reviewed articles that discussed traditional physical therapy interventions alone, and they also looked at articles that discussed ergonomic interventions. What they basically determined was that traditional physical therapy interventions alone can lead to short-term relief of some of the subjective complaints that workers may present to you with. But as far as specific ergonomic interventions, it is very highly individualized to the worker in many cases, and because of that, there's just a lack of quality research out there to support the efficacy at present. And then the final article was a Cochrane review in 2013 that focused on conservative interventions only for upper extremity complaints in the workforce. So they looked at manual therapy, therapeutic exercise, ergonomic interventions, and then behavioral, psychosocial type interventions as well. The only conclusion that could be drawn based on the best available evidence was that ergonomic interventions were associated with decreased pain in the long term. There was a lack of quality evidence for physical therapy interventions and behavioral interventions in the short and the long term. So, big picture, what does this mean? I want you to think about that. That's what we're going to discuss on Tuesday as well. We're going to go through the table, and then I want you to take a few minutes and review the articles and think about how we can implement this into practice and what it means for us as physical therapists. And then we'll go on to lab after that. Thanks so much for listening. I'm super excited to see y'all on Tuesday. And we'll kind of go from there. Thanks.